Okay, well, this is a Tuesday talk, not a Wednesday, so we'll break slightly with tradition and start at 12:04 instead of 12:05. Welcome everyone to a, uh, a special issue of the UCCS speaker series. Again, normally we are on Wednesdays and we continue with our Wednesday talks this summer and beyond, but we've also added something that we've termed the UCCS Summer Symposium on COVID-19, obviously in response to this unprecedented pandemic. And this is a series of related talks that focus on different aspects of the COVID crisis. Some of these talks are on Wednesdays, but many, like today, represent additional programming, and as such are held on Tuesdays or Thursdays, all at noon. So in addition to today's lecture, which I look forward to telling you about in a moment, we can look forward to a panel on safe reopening next Wednesday, July 8th, with Drs. Brad Pollack, Mike Reed, and Amy Sisson. And there's additional talks later in the summer on what history can teach us about recovery after economic shocks, childcare on the brink in the face of the COVID pandemic, and a special conversation between journalists Connor Doherty and distinguished professor Carol Gallant from UC Berkeley about how COVID is affecting the already dire housing situation in California and how it might motivate us to transform policy for the better. So as always, you can find out more on our website, uccs.ucdavis.edu. So now introductions. So for those of you who don't know, I'm Richard Kravitz. I'm the director at UC Center Sacramento. And today we're very pleased to have with us Professor Nam Tran, who is an associate professor in the Department of Pathology and Laboratory Medicine at UCDAVIS. He's also senior director of clinical pathology in charge of COVID-19 testing at UCDAVIS Health, and a recently appointed member of the governor's task force on COVID-19 testing. Dr. Tran has a BS, MS, PhD, and MD, all from UC Davis, so he's truly a native son. He's published widely on molecular profiling of pathogens, biomarkers, and related topics. He's the recipient in 2014 of the Dean's Award for Excellence in Teaching. So please join me virtually in welcoming Professor Tran to bring us up to date on COVID testing. So Dr. Tran, thank you very much for being here with us.
Great. Thank you, Dr. Kravitz. It's definitely an honor to be here. I do have to say, I don't have an MD degree. I think my wife will get upset at me for getting some more letters after my name, despite how exciting it is to go back to school, especially in these unique times. So but definitely appreciate the opportunity to speak with you all. So as Dr. Kravitz mentioned, it's definitely been both exciting, but also a little bit challenging and sometimes a frustrating experience during these times. But I feel when I speak to my staff, these are times where the greatness and the amazing capacity of UC Davis shines, just as any other day, but even more so now. So I'm going to talk about our 90-day evolution of COVID-19 diagnostic testing and how there can be implications for public health and public policy in California. One key thing I want to point out is this information here is for educational use only, and it's current as of today. I do want to emphasize every day things are changing for many different aspects. So please take this as a grain of salt for today's update, and stay tuned as new things pop up. So I'm going to move the slide forward. So quick disclosures. I do serve as a consultant and have presented in the past for Roche Diagnostics on various topics related and unrelated to COVID. COVID obviously being the last month or so. We are a Roche Molecular Center of Excellence at UC Davis, so we've been designated that. So that's why we have some of the platforms here. And then I'm also a co-inventor of a machine learning platform, which I'll mention very briefly. And it's University of California Intellectual Property. So we have 4 quick learning objectives, and it's really pretty straightforward. First is really get you all updated to where we are at, and I think a lot of us are pretty up to date. We see it in the media all day long and all night long and on social media and so forth. But we also want to describe how hospitals have, on average, responded to COVID-19, and in particular, how UCDAVIS addressed it. We want to identify the challenges we face, the limitations we're still dealing with, especially during the pandemic, and describe where we are going and where we should be going in the fall. And that kind of translates into the public health policy that I mentioned. So this is a graphic from, that you've seen on the web of the hotspots across the globe. Obviously, this virus, the first reported case was in China. Of course, it's spread across Europe as well as made its way over to the Americas. And so the numbers continue to grow. This number changes obviously by the minute. And as of June 19th, when I pulled this data, there was over 8.6 million cases in the world. In the United States, you can see that there are areas that are hotspots, and again, these colors change by the day too. But as of June 19th, we also see that there's about 2.1 million cases and 118,000 deaths. I believe it's already past 120,000 as of this morning when I looked it up. In California, we are fortunate that we are a large state and most places aren't densely packed, except for in Los Angeles County. Los Angeles County does have the greater proportion of cases. I believe it's about close to 50% of the cases in the state. But total cases as of June 19 was greater than 161,000 and over 5,000 deaths. This figure on the left you see here is really what a University of California Health posts on Twitter, and you're more than welcome to look at it. And you can see what ratios each hospital within the UC Health community is testing. So there are 5 UC Health medical centers, so San Francisco, San Diego, Los Angeles, Irvine, and Davis. And we're all testing at high capacity, but different proportions because a different degree of how we're reaching out to the community, the prevalence, how many symptomatics are coming in, but you can definitely see the big hotspots are centralized in Southern California, and these continue to change minute by minute, as I noted. Heading into this pandemic, so February for us, and more so late February, is that we were fortunate in our department, and I report to Dr. Lydia Howell. She's our CLIA director as well as our chairperson, and we've been formulating what we call the Center for Diagnostic Innovation for about over a year. And this is the realization that the clinical laboratory, the Department of Pathology and Lab Medicine, carries with unique resources that can help move new technologies forward at a much faster pace. And we've all heard that phrase, translating technology science from bench to bedside. But what we strove to do with the Center for Diagnostic Innovation is really to translate not only from bench to bedside, but to actual implementation. And implementation is key, and the implementation science is very important because we also have to capture important metrics such as, are we actually making a difference? So the quality of care. Did we save money? Did the patient experience improve? Can we integrate what we learned into new algorithms such as machine learning? And so the very top black box up there, the Machine Intelligence Learning Optimizer, that is our intellectual property at UCDAVIS. Dr. Houman Rashidi, who's a co-inventor, and I'll give him all the credit for being the programmer of it too. We developed a machine learning algorithm or system that generates AI models, artificial intelligence models on a grand scale, so we can find the best models to predict certain diseases. And we've been successful in publishing that, and we're obviously now also looking at COVID. But at the middle frame, at the bottom, you'll see something called Diagnostic Impact and what we mentioned as a CAP-accredited biobank and clinical services. All clinical laboratories in the United States are regulated by the federal government, and they may or may not be accredited by other agencies. In our case, we're accredited by the College of American Pathologists, which holds us to a higher degree of performance than the federal government. But we have these amazing technologies, such as robotics, to do 5.5 million tests per day, just for as an example. Everyday tests, glucose, electrolytes, cardiac biomarkers to see if you have a heart attack or not. And we also save these samples after patients have consented. The patients have given their input that they're okay with us saving their samples. And we bank these samples in the event we need it for patient care, in the event that we need it for future research to help develop new therapeutics and so forth, and hopefully address future problems. And of course, you all know what future problem we're talking about. And this is our journey, and this timeline we've been presenting for quite a while illustrates where we were. So I want to first start off with around November, December, when we started hearing about this virus in China. And knowing, having gone through a couple pandemics in my career, we knew that at least with a respiratory pathogen, we knew there was going to be an increase in respiratory testing, even though at the time in November, December in the United States, we did not have a test that could test for COVID-19, SARS-CoV-2. But we knew that flu was still around, so we increased our supply of these reagents early on. Again, this is for regular respiratory testing, not for COVID. Come February, the numbers are starting to creep up. We have tourists and Americans that lived outside the United States in some of these hot areas now flying back, coming to Travis Air Force Base as an example. And the threat of potential community spread was growing. But at the time, there was no COVID-19 assay available to regular places in the United States. By February, we were still restricted to sending to Atlanta at the Center for Disease Control and Prevention. And that seemed to be okay, where every now and then we run into a person under investigation, or a PUI, someone that would be a good candidate to be tested for COVID. They'd be tested, and this is amount of people per day I could probably count on my hand, if not less. However, in late February, UCDAVIS ran into a unique case, which ended up being the first community-acquired case. Due to delays in testing, which I'll go into detail in subsequent slides, this is related to the CDC rules at the time. We were able to help, as an institution, have CDC update their guidelines to make it a little bit easier to get testing for individuals that are suspected of having COVID. But also, by then, around after February 12th, the CDC's COVID test was found to not be working at public health labs. So the FDA responded by allowing on February 29th, and I remember this day well, February 29th, they relaxed the regulations and provided instructions on how to submit our own tests, i.e. UCDAVIS or any other hospital or commercial lab, to produce their own COVID-19 PCR or molecular assay. And that's when the clock started. Within 24 hours, we were ordering reagents. We were stockpiling up and getting folks settled to begin validating. And validation is a required federal element for bringing up a new test, where you have to make sure it works. You want to have a good test or not. And by March 19th, UCDAVIS deployed the first PCR, so polymerase chain reaction. We'll talk about the technology for COVID testing. And in about less than a week after that, we brought up one of the first high throughput platforms there, the robot you may have seen in the news recently, which can do up to 1,000 tests per day. And then we continue scaling thereafter. And you may have heard from our media sources that, at UCDAVIS, my group and I came up with a plan is to start testing early, scale to a larger number because the numbers are going to grow, but then focus on target populations such as emergency room patients and people who are going to emergency surgery, so that we can actually still test them and protect our healthcare workers too, with faster tests, which we deployed by April 30th. We also deployed serology testing and brought in a backup. It's not April 4th, but that was April 4th and /5th on there. But we brought up a second high throughput analyzer in the event that there is maintenance on the first instrument. And also, which I'll highlight, we still have to do regular patient testing. So these instruments need to be, they can't just be fully devoted to SARS-CoV-2 testing. So one of the reasons why we were able to adapt so quickly was the biobank. So I've already highlighted that we have an accredited biobank. It's appropriate for us to save samples. We have amazing patients that volunteer their specimens for us, and we keep them for this purpose. And we were able to use leftover samples of COVID-19 patients to then validate these instruments. There were hospitals at this time that were begging us to get samples. They have not seen a single positive patient yet, which means they don't have a positive patient to determine if their test can pick up COVID. That's what the federal regs require. You have to show accuracy. If you have a patient that has COVID, you should be picking up the virus. If the patient doesn't have COVID, you should not be picking up the virus. So we had a supply of samples, of respiratory samples, as well as blood samples. And the blood samples downstream, as we got more and more COVID patients that were recovering, we now have a bank of serology samples. So now we also have the ability to look at their samples and see if they produce antibodies. So we can learn from it, but also see truly, if people are mounting some sort of immune response. And we'll talk about the limitations of that very shortly. Knowing that there was a massive shortage of virus to go around, which sounds kind of ridiculous, but we need the virus to validate. So one of the first things I did at the time was called up our colleagues at UCDAVIS in the city of Davis, not in Sacramento, the Center for Immunology and Infectious Diseases. And in the past, my PhD was in comparative pathology. We have close relations with this group. And we asked them, can you culture this virus? And they have what's called a biosafety level 3 facility. It's a higher secure facility that allows you to grow more dangerous organisms, such as SARS-CoV-2. And you can see my colleagues down there who are wearing their semi-spacesuits to do this job. And they did amazing work. And within a week or two, we had a supply of viruses that we could use for many different reasons, including injecting into research animals to be able to study the immune response so that we know if we have immunity or not. We did primate studies to look at how potential vaccines and so forth. So through this collaboration, we've been able to facilitate our understanding of how convalescent serum should work. And of course, lots of researchers now focusing on vaccine studies. So this is amazing work by our CIID colleagues, as well as the California National Primate Center, all at UC Davis. So you can see there that UC Davis is uniquely poised to do this. Not many other places can pick up the phone and call their colleagues down at the Primate Center. So here's that sentinel case in late February. This was an individual who was in their 40s. They had no travel history to high-risk countries at the time, but they had 3 to 4 days of flu-like symptoms. Their chest x-ray showed that they had a respiratory issue, and it was screaming, for at least for our intents and purposes, potential COVID-19. And they were at an outside hospital, which they transferred this patient to us because they were developing severe respiratory distress and septic shock, which is pretty much an over-response to an infection, which you see in COVID. This was published in the CID journal earlier this year by our infectious disease colleagues. I'm not going to ask you all to pay too much attention to this timeline, but the take home was you could see around a little bit late day 2, they were already considering transfer. A little bit midday, day 4, COVID-19 suspected, testing was discouraged. So CDC said, no, you may not be a candidate to be tested for COVID-19. Not until about 48 hours later were we at UC Davis allowed to do COVID testing, which of course was found to be positive. And this patient received remdesivir, which at the time was an experimental drug. And of course, this patient recovered. So how do we do all this testing? And I feel it's very important for many different levels of the community. You don't have to be a physician or a PhD, a lab scientist, but it's very important for the lay public to have a basic understanding of what these tests are and why we have them and their potential limitations. What do most people think about COVID testing? Well, really, it comes down to 2 approaches. I'll speak for the first at this point, which is molecular testing. And when you hear the word molecular, we're looking at the genetic makeup of the organism. So DNA, RNA. In this case, the virus is an RNA virus. So there's a couple steps we have to do with these technologies to measure and amplify that signal. One of the most common technologies is PCR, polymerase chain reaction. This picture illustrates that process. And the take home for everyone is that PCR takes one strand of nucleic acids, RNA or DNA, and it amplifies it many orders of time. So that every cycle of PCR, it doubles the amount of nucleic acids that are there. So 2 strands become 4 and so on. So these are things that help us pick small amounts of virus up and with great specificity, because the genetic makeup of viruses in ourselves are pretty specific. And so there are ways for us to leverage that to know what's actually there. This slide may look complicated, and all it is it's showing the genome of the SARS-CoV-2 virus. And of notable, there are at least 5 regions that we try to target with our PCR test. But you'll note that on the left side, you see different manufacturer names, the CDC, Thermo, Japan, the country of Japan deployed that, Hong Kong University. What I want to highlight here is, and not to belabor the abbreviations, is every test that is out there are targeting different things. And this emphasizes an important point that not all tests are created equally. And we currently can't compare how one test is good or bad versus the other because they are effectively apples to oranges. So the CDC test targets regions within this N gene, whereas you can see the Hong Kong University, they do one part of the N gene, but then something called the ORF1b region. So there are differences, and this translates into the challenges we face today when everyone's trying to scale testing, bringing whatever tests they have, but we don't know truly how these tests are performing under much more rigorous conditions, because the clinical trials were never deployed for this, because these were all emergency use authorized tests that were deployed very quickly by manufacturers and other institutions. At UCDAVIS, we have 3 primary assays. We've actually deployed a 4th more recently. The first row is the platform that is high throughput. We do 94 samples every 3 hours. These have to be batched. Batched meaning that I have to run 94 samples at a time. We're quite proud of this system because it gave us the capacity. But we're also quite fond of that second row, which is the CDC assay. And that was our first test. You always feel proud of the first technology you deploy. In this case, it was the first SARS-CoV test in the region. And this test was a little bit slower, and about 4 hours, running in batches of 21. The third test is another platform that is fast. And what is also important is that it's random access. Random access means that I don't have to batch. If you send me 1 sample, 2 samples, 4 samples, up to 12, I can run any of those combinations. And I can get results back in about 1.5 hours to 2 hours. Those numbers there are important to look at. So specificity, that we're calling this a specificity, you want that number to be very high, and it is. In these cases, we believe that these tests have a specificity of 99.9% or greater. And it means that in the case of 99.9% specificity, it means that you have a 0.1% chance of having a false positive. There's a 0.1% chance that this test will give you a positive result when you didn't have COVID. That's extremely low. Sensitivity, on the other hand, tells you how the true positive rate of this test. And in the case of, say, the third row below, 94.4, just say 94%, it means that you have a 6% chance of having a false negative. That's also relatively low, but that's where we have to be more concerned about, because we don't want false negatives, right? We don't want false negatives because we could send someone home that may have the virus and they can infect others. And the reason why that number is so low is for many, many, many reasons. First, something called viral load. Viral load is how much virus you have in your body and in that sample that you collected. These are 4 different sample types. And something called bronchial alveolar lavage, that's a very invasive procedure. You and I are not going to be the ones that are going to get that, but you're more likely to get a nasal pharyngeal swab, which is not really desirable because of how uncomfortable it is. Oral pharyngeal swabs and even saliva samples have now been proposed. But you'll notice that as you go away from nasal pharyngeal swabs, the number of the viral load on the right gets smaller and you get question marks in saliva. As you move away from where the virus sits, you may have less and less virus to capture on that swab sample or the sample in itself, and you have a higher chance of false negatives. In addition to that, if a nurse or other healthcare provider didn't collect the sample correctly, not because they were not good at it, but can you imagine a person getting a swab shoved up their nose? They might not be sitting around calmly, right? They might be moving around, wincing and so forth, and that could also create situations where the swab didn't capture the virus. So if you didn't get a good sample, there wasn't enough virus in the sample, you might not pick it up, hence the false negatives. Saliva, lots of question marks there. I think it's a good sample and we are looking at it at UCDAVIS like many other places, but there's still a lot of questions because saliva has enzymes in it that eat up RNA, and RNA is the stuff that we're looking at for the virus. But also saliva, as we all know, is viscous. So if you have a sample that's highly viscous, your instruments can't move the samples using pipetters and so forth, and they get stuck, and they might cause problems with the analysis. So there are challenges with that, which we are all studying as we move along and trying to get it up to speed as soon as possible. Another topic is that viral kinetics also matters. And so in this case, we see that the virus changes over time. When you're recovering from the virus, some days you have more virus being shed, some days you're not. We've also found in literature that sometimes RNA is being shedding and the virus is not being shed, and so therefore the patient's not infectious. That's why you've heard of cases where the patient was still positive, even though it was a month later after they got out of the hospital. So the PCR test, the molecular test really fall under diagnostics. I'm now going to switch gears to talk about what happens after you recovered. So these are the antibody tests. So on the left, you have your molecular test. Now on the right, I'm going to introduce immunoassays. When you hear the word immunoassays, we're now using immunology. In this case, antibodies we've designed to target other things. And in this case, with serology, we're targeting antibodies that you and I produced after exposure to a disease, in this case, SARS-CoV-2. What we understand before heading into this is that typically you get exposed to the virus, you generate RNA because the virus is multiplying, so the RNA of the virus is being produced in large numbers, and your body, after about 7 days or so, has encountered the virus enough to learn to produce antibodies. Sometimes they can be produced earlier, sometimes it takes longer. And there are several types of antibodies, something called IgM, which shows up usually first. It's not as specific, it's just there to kind of grab onto these invading organisms to try and mitigate and slow down the infection. But it's early, it's nice, it shows up early. IgG is another antibody that we produce, and it's much more specific. It's much more helpful in the immune response and perhaps can confer immunity. And this takes another couple days to respond, sometimes by day 14. So that's why most of these serology tests measure these two antibodies. The problem is, as we start talking about serology testing around March, maybe April or so, a lot of people were thinking this was the panacea, this was the silver bullet. I need my serology test so that I have my thumbs up to be able to not worry about COVID. The problem is not all serology tests are created equally. And it's not the answer to everything as much as folks wish it could answer everything. Some rapid serology tests were proposed in the media. And because the FDA wasn't cracking down on these, anyone could have bought them, and people did. And these tests were known to have a higher false positive rate. In fact, the United Kingdom government paid $20 million for these tests and had buyer's remorse. They didn't work. So when you have a 30% false positive rate for a serology test, that's terrible. And that's because if you have a positive result and the person is going to go home thinking they're immune and they're not, that's a big problem. So this pretty much resulted in a lot of bad data being generated in the community. Here's a study from a local, or at least in California, institution that used these rapid tests, and they suggested that the prevalence rate was this, and only to find out that they used these rapid tests that had a 30% false positive rate, which could suggest that the results that they saw were inflated by 30%. And there's a lot of controversy with this. But at the end of the day, serology tests are here to tell you if you may have been exposed to an infection or not. Typical assays target antibodies we made against parts of the virus. However, some assays may pick up antibodies we produce against non-SARS-CoV-2 viruses, such as coronaviruses that cause the common cold. Neutralizing antibodies, the antibodies that actually stop the virus from invading your body, are of extreme interest, and only recently are there now assays starting to become available. However, we don't know if immunity actually occurs and how long if it lasts. There's a study that just showed up this morning, I believe it's from China, that after 2-3 months in people who are mild symptoms or asymptomatic, the antibodies disappear. It doesn't mean that they're not immune, but the antibodies disappear. What does that mean? We don't know. But what we do know is that the severity of your illness does seem to suggest how much antibodies you produce. So this is a nice paper that was published in Nature Medicine that shows that if you have more symptoms, you typically make more antibodies. And so these are things that we kind of have to look at as we kind of tease through the actual data. And does this apply to everyone? Does it apply to adults, elderly, young people? We will have to see. Still a lot to learn, unfortunately. So at the end of the day, as we're still all learning in society, we recommend this. If you're trying to diagnose COVID-19, you're still doing a respiratory sample. In our case, the NP swab. If you're testing someone who's asymptomatic, they're not presenting with symptoms, you could probably do the serology test, but you have to have that molecular test, the NP swab. Because why do we do that is the NP swab still catches early infections and antibodies show up later, right? We already learned about that. And then if you're looking for population screen to look at how bad exposure to the virus is in the community, then maybe serology by itself is more useful. At Davis, we deployed 2 serology tests, and we've recently switched completely over to the second one, the second row. And we've been quite happy with it, but also been heavily educating people on the limitations of that. Because given how these tests perform, and I'll go to the next slide, prevalence is an issue. And I don't want to belabor this because this goes into heavy statistics. But if you have a highly specific test, you can see there in that first row on the left, this test has 99.81% specificity. That's darn good. But if the prevalence of the disease is low, say 1%, what we call positive predictive value, which is the probability of a patient testing positive for disease actually having disease, is actually 84%. That means there's 16% chance that what that positive result was false. We'll leave it there, but prevalence influences how good these tests are going to be, not just how good of a test you can buy. And this is the other challenge that we've been facing right now. In fact, the CDC and the state task force, in the state task force in particular, we all agreed that if a hospital is going to adopt a serology test, it has to have a specificity of greater than 99%, because if it's below that, it's worse than guessing in terms of if your result is real or not. And I'm not even kidding for that. I believe sometimes some data I've seen is down to 49% positive predictive value. I'm going to skim through this just for the sake of time, making sure we're staying on time. There are other tests we perform which are done every day. And this patient that came in had a variety of tests that were done. Lots of numbers there. Again, not there to confuse you, but in short, physicians have a significant armory, a chest, a war chest of being able to look for many different types of results that can help suggest if they have COVID-19 or not. One of these is a biomarker called procalcitonin, and we'll talk about something called interleukin-6. Procalcitonin has been around for a while. Actually, we brought this test up around 2014, and this test typically looks at bacterial infections. It's normally low or not detectable when there's a viral infection, and that's typically the case for early presenters of COVID. But what we've also found is that patients who get really sick with COVID-19, procalcitonin starts rising. That seems to be contradicting, but what we understand now is it's partially due to the tissue injury from the COVID-19 and perhaps other infections that are happening in parallel that cause the PCT or procalcitonin levels to rise. Interleukin-6 is a new one, and none of you or most of you may not have heard of this in the regular community, but this is starting to appear. There has now been an IL-6 test that has received FDA emergency use authorization. And more importantly, the CDPH, the California Department of Public Health, has included IL-6 as an indicator if a patient has multi-system inflammatory syndrome, and this occurs unfortunately in children, a small number of children. But IL-6 also helps evaluate if there's a cytokine storm. So cytokines are these molecules that are released by the body's immune system to help tell the body to ramp up in fighting an infection. So with high IL-6, typically meaning that you're not in good shape, there's also now interest in using drugs that block IL-6 response to the body. So there's data right here that shows that people who die of COVID-19 having significantly higher IL-6. So IL-6, having a lot of IL-6 is not a good thing in COVID-19. So with these drugs, if you can prevent release of IL-6 or alternatively block the binding of IL-6 to the receptor, such as this drug right here, these are examples of how this could be helpful, and these studies are ongoing. Looks like results are promising, but just as we look in our crystal ball, we still don't know yet until the numbers get bigger and so forth. And there's other types of drugs out there as well that try to bind and block IL-6 and binding to the receptor. So going back to this, I'm going to close out this last third of the talk on our barriers. And you look at this timeline, and we're quite proud of it. We've done a great job. Our amazing lab scientists were working day and night to get this going as fast as possible to help our patients and our community. But we ran into barriers, and we still have barriers to still overcome. Early on, it was reagent supply. It wasn't just the reagents for PCR tests. They were worth their weight in gold, but we found out there was a short supply of extraction kits. Extraction kits are chemicals we use to rip open the virus to be able to test and amplify that RNA. So how we got around that was we brought in other platforms that didn't rely on these kits. So we were trying to stay ahead of the demand curve. Every time we start running short, we have another instrument. That's why we have 3 instruments, and actually 4 now. So these are the instruments we deployed, and quickly moving on thereafter. PPE was still a challenge. It wasn't nowhere as bad as New York, but it was still limited. But our personnel, laboratory personnel, even though they may not see patients directly, we're handling highly concentrated samples containing the virus. So we have to have PPE. So these are things that we had to deal with during that course of time. Believe it or not, we had swab shortages. No swab, no nasal sample, and no testing. So those are the challenges we faced there. And through the California Task Force, which Dr. Kravitz mentioned I was a part of, and we still are, and I'm very proud to serve with many amazing colleagues. They were able to open up supply chains to get us more swabs. Every day is a new day, but they were able to free up a lot of swabs for us and help a lot of hospitals in the state. We also ran into challenges with media. So you have the swab, but you don't have anything to store the swab in. That's also a challenge too. No media, no testing. But again, the state helped in that regard. We've also now opened up supply lines to be able to build or manufacture our own media. That's happening now as we speak. We have a facility here at UCDAVIS, the GMP facility is producing it. And we looked at 3D swabs, but now we're looking at buying these 3D printed swabs from commercial vendors who can generate these at large scale that we need to continue to expand over time. Other challenges we faced was personnel shortages. Our original thought were people and personnel being sick. They might catch COVID and they have to stay home. They get quarantined. The reality for us was that majority of people who stayed home were because they had to take care of loved ones, completely appropriate. Schools closed. You have to stay home with your young children. So these are things we had to deal with, while at the same time we had to scale up testing. So those were challenges that we faced personnel-wise. Fear, anxiety, and concern by bedside providers, all completely justifiable, all completely understandable, and everyone wanted faster results. But I think folks in the early days had a hard time understanding that the test takes 3 to 4 hours. It was better than 2 days going to CDC, but fear and anxiety were a challenge. And we had to come up with ways to best educate people so that over time, the anxiety kind of goes down to a more manageable level and people have realistic expectations for these types of tests. So how are we doing in time? We're doing great in time. So where do we go from here? And this crystal ball, I may have jokingly should have switched it to a magic 8 ball and saying come back later. But we know that prevalence is increasing again for COVID-19. We now have access to more testing compared to early February. We had nothing. No hospital had a test. Now we have testing and at scale and at speed for select populations. However, as we now have stability in terms of scale, the demands for testing are now going higher than they were in February because we're opening back up and there's more and more patients that are symptomatic coming in. And this now has put a strain on reagent manufacturers again. Swabs and media are in short supply again. There's never enough reagents. There's never enough swabs and media. That's why I say schools and companies are opening up again. And the question comes up, should we test? How do we test? Who do we test? We want to test everyone, but do we have means to test everyone every day? No. So strategies moving forward, and this is some expert opinion on my end and what we're looking at. And this is continually evolving. So please bear with me. We have to come to terms with there's a difference between perceptions to test versus the clinical need to test. We are still living in a resource-limited setting. In the fall, there's going to be more, unfortunately, and we're going to be fighting that with the flu. But we have to prepare now. There's some talk of antigen tests. They're not good enough. I don't think they have been able to be achieve the sensitivity specificity we need to deal with this test. At UCDAVIS Health, obviously, we are testing all symptomatic patients. Anyone who's positive within the community, we try to contact trace, and obviously a big role for the Department of Public Health. We're testing anyone who's been admitted. We're also doing symptomatic testing of symptomatic and at-risk individuals with these technologies that we've talked about. In terms of contact tracing, this is pretty interesting stuff. Our amazing infectious disease and infection prevention teams at Davis, as well as our colleagues at CDPH, the Public Health Department, they do this all the time with other diseases. But in COVID-19, finding that first person who's positive and then identifying who was near them and how long and what interactions defines their level of risk for having it. And what we are going to push and continue to push, and we've been doing this, is that we're going to test that first case and then start testing these individuals who were around them to determine if they have the disease or not, or if they had a prior exposure, just again, to contact trace. But we've also deployed unique technologies such as sequencing. For every time the virus infects someone, there's minute little mutations, nothing scary, but minute mutations that allow me to determine if this virus came from patient number 1. So in this case, you'll see at the very top right there, you see those four blue dots and 1 yellow dot. The yellow dot is the original individual who was positive with COVID. The 4 blue dots were the people that were around them. We were able to find that the sequence of virus was pretty much the same or similar enough to say that the person who was originally infected transmitted to these other individuals. So we're now able to genetically determine the relatedness of transmission of this virus. So we know where clusters can show up and allow us to better contact trace. And this is in collaboration with the Chan Zuckerberg Biohub in San Francisco. They do all the sequencing there. And this is amazing work, which I believe that, there's efforts now to see how we can do similar things at the state level with the Department of Public Health. And that's the patient cluster there. So having this multi-tiered approach to testing is key. We have on the left high throughput systems. I can get results back in 24, 72 hours. We're actually faster than that presently. But as numbers of samples come in, increase, we will continue to flex with that. But we have rapid tests. About 1.5 to 2 hours. It says 2.5 to 3 hours here because you have to account for the time it takes to transport the samples to us. So beware of that. But there's still a gap. We still are missing a PCR test that can be done at the bedside on a scale of minutes. And that doesn't exist right now. There is a 5-minute test, but there's been some controversy that platform may be having too many false negatives. But there are many tests that are in pre-FDA right now, so hopefully something will come out. What about academic campuses? UC Davis has an academic campus. Well, this is a whole nother game. We have to look at testing a grand scale. We have 35,000 students at Davis plus employees. And COVID-19 is a dynamic disease. So if we test a person once or 35,000 students at once, it's a snapshot in time. Nothing's keeping them from getting the virus tomorrow or next week. If we test them every day, we're going to run out of supplies. So we're looking at what are called pooling strategies where we can test more with less. These are amazing things by our molecular director, Dr. Sandy Borowski. He's working on this now. And we're looking for other sample types. So it'd be nice to use saliva and perhaps other means, but there's not clear data on that yet. Self-collected samples are something we're looking at as well. And new antigen tests, unfortunately, still haven't met the bar yet. So we still can't use antigens. But we're trying to come up with ways to test more. But again, similar methodology, symptomatic cases coming in, contact tracing, and then symptom tracking and so forth. So models that we're discussing about too, and this is not just for UC Davis, but many other campuses out there, do we have mobile teams that go out there? This is just a question mark. This is just things I'm hypothesizing. Do we have mobile teams that drive out to the person's house who's positive so they can stay home, to stay quarantined? Do we forward deploy faster testing to other places that need it? And so forth. So all these things rely heavily on a robust symptom screening tool. Do we use apps? Do we do smart devices? Do we just ask people questions? And then being able to contact trace quickly. All these things are hugely important and obviously in discussion right now at many campuses across the nation. So in summary, we are still in a pandemic. in dealing with high demands for SARS-CoV-2 testing in a resource-constrained world. That's the unfortunate truth. Not all tests are created equal, and many institutions have had to resort to multiple platforms to overcome these resource limitations. Fear and anxiety and false knowledge and assumptions can drive unnecessary demand. That's going to cause an exacerbation of our supply issue. An institution like UCDAVIS have established innovative measures to overcome these barriers, as I've shown you. In terms of public health policy implications, and perhaps it's more so questions for you all, how do we define means to optimize testing? We are resource limited. How do we provide testing to people that need them to prevent infection, provide appropriate isolation, and determine recovery? Questions to you all: should schools reopen? Can schools resume if we provide routine testing at the cost of depleting resources for other populations? How do we increase manufacturing needed supplies and manufacture of needed supplies so we can offer to more people? There's a lot of confusion and lack of understanding of diagnostic tests. How do we better educate the community on these limitations and what we should do for both public health, the medical community, and of course, general knowledge in the public? And lastly, how do we support COVID-19 testing without compromising regular testing services? Those two robots I showed, two robotic PCR analyzers I showed you, we're lucky we were just got them in December, the first instrument. And so we didn't move our regular tests over to that yet. So other hospitals aren't as lucky. They were probably doing HIV testing, hepatitis C testing. So now they're balancing that with COVID. So all these regular patient care are happening in the age of COVID. And I will stop there now. I do want to acknowledge all the amazing lab scientists. They received an award yesterday, which we're very proud of them for their hard work and so forth. Our ID doctors who are amazing partners, infection prevention nurses, ER docs, and many other physicians within the health system, nursing and pathologists, and many, many more that contributed to this. So I'll stop there for the sake of time to answer questions. Thank you.